All right, class. Today we are getting ready to start chapter 9. And so this is kind of a continuation of the skeletal system that we just talked about in chapter 7. Except instead of just talking about the bones, now we're actually going to start looking at the joints of the body. And so when we look at the joints, we classify them in different ways. But the first thing we look at is the name of it. And so another name for a joint is actually an articulation. And so the definition of an articulation or a joint is essentially places of contact where the bones and cartilage, or bones and teeth actually come together. Uh, Arthrology is the study of joints. And again, we have different classifications of them. And these are classified based on structure and function. When we look at the structural classes, so again, structure is basically going to be what it's made up of. And so looking at the structural classes, we have what we call a fibrous joint, a cartilaginous joint, and a synovial joint. When we look at our fibrous joints are where bones are held together by a dense connective tissue or some sort of fibrous connective tissue. A cartilaginous joint is where bones are held together by cartilage, and a synovial joint is where the bones are joined by ligaments with some sort of fluid-filled joint cavity that actually separates the bone surfaces. We also classify joints based on functional classifications, which basically refers to the amount of movement that they have. These classifications are going to include a synarthrosis, an amphiarthrosis, and a diarthrosis. With a synarthrosis joint, these are immovable joints. They can be classified as a fibrous or a cartilaginous joint, but again, these joints basically have zero movement in them. An amphiarthrosis is a slightly movable joint. Again, these can also be fibrous or cartilaginous. Now, a diarthrosis is basically a freely movable joint. All of these types of joints are going to be synovial joints. So when we look at the movement, we have to look at the range of motion at the joints. Now, motion can actually range essentially from no movement to extensive movement, really of which we just saw in the functional classifications. But in order to determine the amount of movement, that really is determined by the structure of the joint, and that helps to determine its mobility, but also helps to determine its stability of a particular joint. When we look at the joints, there's an inverse relationship, which basically means there's some sort of trade-off between mobility and stability. So essentially, the more mobility you have, the less stability you have, and vice versa. So for example, skull suture joints essentially are immovable. So because they're immovable, they actually become very, very stable. So here we look at the relationship between mobility and stability in joints. You can take a look at this graphic in your book, but basically it just kind of shows you some of the classifications from fibrous, cartilaginous, and synovial, and then also just kind of shows you the mobility versus stability relationship. So let's look at a few characteristics of the fibrous type joints. Again, we said these are connected by a dense, regular connective type tissue, so some sort of fibrous tissue. They do not have a joint cavity, okay? And again, when we look at their movements, these can either be immovable, so they can be synarthrotic, or they can have slight movement, which means they can be amphiarthrotic. The three most common types of fibrous joints are going to be a gomphosis, a suture, and a syndesmosis. And we'll talk about those three here coming up. So let's look at a fibrous or a gomphosis type fibrous joint here first. The gomphosis is more of a peg and socket type joint. We're going to see these in the articulations of the teeth as they go into the sockets of the mandible and the maxillae. The tooth is essentially held into place by a fibrous periodontal membrane, or what we also call a periodontal ligament. These are going to function as a synarthrotic joint. If you kind of grab your teeth, you'll notice that they really don't have any movement, or I should say they aren't supposed to have any movement. And so when you see this tooth go into the socket, you can see along the side here we have the periodontal membranes, or what we would normally call the periodontal ligament. And you can see that as it goes all the way around, and how that tooth actually sits right into it, and how that ligament really is attaching the tooth to the bone, in this case, the mandible first. Our second type of fibrous joint is going to be a suture. Now, sutures are going to be found in the skull bones, and you can see the graphic here, how it basically is kind of this woven region. If we take out this little window here and blow it up, how it all kind of fits together like a jigsaw puzzle almost. We have these interlocking, very irregular edges, and by interlocking these edges, it helps to increase the strength and decrease the risk of fracture. It's really important, obviously, because the skull protects the brain, that we have a very stable area that protects that particular organ. Again, these are going to function as a synarthrotic joint, which means there is no movement in there. But as we are growing, or as we're in childhood, it does allow for growth while we go through this phase. And as we get older, they end up becoming what we call an ossified synostosis in older adults. So here we have a little bit more of a cartilage base per se as we're developing, but once we turn into adults, it ossifies and they become these synostosis suture type joints. Our third type of fibrous joint is called a syndesmosis. Now, syndesmosis is going to be bound by an interosseous membrane, or what we would consider a broad ligamentous sheet. A couple examples here. One is going to be between the radius and the ulna, but we also have an area between the tibia and the fibula. If you look here between the radius and the ulna, you can see the two bones there. Here we have the syndesmosis, this interosseous membrane. Now keep in mind, when we talk about interosseous, that basically means between bone. So this is kind of the ligament that falls between the two bones. This particular joint functions as an amphiarthrotic joint. So there is some sort of slight movement. It aids, it doesn't necessarily give rise to the pivoting movement, but it does allow for some sort of pivoting movement as these two bones, as we kind of roll your wrist over and back, it allows for movement of the radius and the ulnar. And we really call this pronation and supination of the wrist. Now, there's also the pivot joint up here, which we'll call the proximal radial ulnar joint. And this is what we're going to learn is going to be a pivot joint. And it's what actually allows the rotational component here. And then these two bones in this joint of the syndesmosis type will actually allow the bones to roll over top of each other. So now we move into the cartilaginous type joints. So here's a couple properties of cartilaginous joints. One, they're going to be joined together by some sort of cartilage, whether that's a hyaline cartilage or a fibrocartilage between the two bones. Cartilaginous joints do lack a joint cavity, and these are going to be immobile or synarthrotic, or they're going to have slight movement or amphiarthrotic. And the two types that we're going to discuss are going to be a synchondrosis and a symphysis. And you'll notice here, synchondrosis. So we're going to see that chondro term, which indicates a cartilage component. So when we look at a synchondrosis joint, the bones are actually going to be joined together by hyaline cartilage. In a synchondrosis, these are immobile joints, or they are synarthrotic. So if we look at a couple examples here, one thing to note before I get into these examples is when we go through these types, that's going to be one of the things that you certainly want to know. You're going to want to know kind of the structural makeup of these joints, but also you're going to want to have an example of each of these specific types of joints, which we certainly cover on each of these slides. And so when we look at the examples of a synchondrosis, here we have the epiphyseal plate where we have a hyaline cartilage section that joins the two bones together. In this case, it may not be two specific or two separate bones, but it is two separate pieces of bone here. Now, obviously, as we get older, this will ossify and become the epiphyseal line, and at that point, it's no longer a synchondrosis joint. We also have the regions of the ribs, so the costochondral joints. These are immobile joints between the rib and the costal cartilage. Now, there is a little bit of movement, but again, particularly the movement is going to come more from the backside as they come into the vertebrae, not so much up in the anterior portion of the rib cage. Our second type of cartilaginous joint is going to be a symphysis joint. And a symphysis joint is where we have a pad of fibrocartilage that's between the articulating bones. And this fibrocartilage is actually a little bit tougher. And so what it does here, you'll see this, is it resists compression and it acts as a shock absorber. And so when you really look at the couple places that we're going to see this, really the pubic symphysis, it's going to help release or act as a shock absorber for gravity coming down onto the pelvic bones. And then the other place that we see this fibrocartilaginous pad in a symphysis joint really is going to be in between your vertebrae. And this is going to be the intervertebral disc is going to be kind of that fibrocartilaginous pad. So let's look at a clinical view here, and let's look at costochondritis. With costochondritis, obviously knowing the term, costo refers to the ribs, chondritis refers to the cartilage, and itis itself refers to inflammation. So when we say costochondritis, we basically are indicating that we have inflammation here. Let me go ahead and pull this up. So we have inflammation of the rib cartilages or the joints themselves. So we have inflammation of the costochondral joints. And so what we're going to typically see is some type of localized chest pain on the anterior component of the chest. The cause usually is unknown. It typically is some sort of trauma, but can be some sort of infection as well. But because of the location, because it's really into the chest area, oftentimes it can be mistaken for pain from a myocardial infarction or what we know as a heart attack. Oftentimes in the medical community, it can be treated with non-steroidal anti-inflammatory drugs or NSAIDs, which basically are the over-counter type of medications. From a chiropractic perspective, oftentimes we treat it conservatively. It can involve adjustments to that area. It can also include nothing more than just making sure that we get some ice on it as well. So again, it just kind of depends on the severity of that particular condition. So now let's look at our next type of joint, and that's going to be a synovial joint. So we have a lot of different distinguishing features and characteristics of synovial joints. When we look at synovial joints, the bones are actually going to be separated by a joint cavity. So we don't necessarily have a direct bone-to-bone contact in that particular joint. There is a little bit of a space between it. This is the type of joint that we find in most of the joints of the body. We also see, or we often find most of them really in the extremities, but we will find them in other locations. These are diarthrotic joints, which means they are freely movable. Now, they may be limited in certain planes of movement, but as far as the particular planes or the particular movements that that joint has, they often are freely movable. And here are a few basic features that we find within a synovial joint. We are going to find an articular capsule as well as the joint cavity. It is going to have synovial fluid, which is going to fill that joint cavity. we're going to have articular cartilage, which again, we said before, is going to be the remnants of the hyaline cartilage template, and it's going to cover the articular surfaces. And then we're going to have ligaments, nerves, and blood vessels in and around those synovial joints as well. So if we look at the synovial joint, again, this is just what we would consider a typical synovial joint. We have the bone here and the bone here. This surface indicates the articular cartilage. And so that articular cartilage basically allows for nice, smooth movements, as does this joint cavity that's going to be filled with this synovial fluid that we'll talk about. You'll see here we have an articular capsule that kind of surrounds that particular joint, and that gives us two different layers, a fibrous layer, but then we also have the synovial membrane, which is going to be the inner layer. So let's look at some of these distinguishing features of the synovial joints, and we'll look at a little bit more specificity with some of them. So the articular capsule is a double-layered membrane. We have that outer fibrous layer, and it's going to be mostly a connective type of tissue. And what it does is it helps to strengthen the particular joint in order to prevent bones from being pulled apart. We also have this synovial, or the inner membrane, and it's going to be composed primarily of an areolar connective tissue. And it covers the internal joint surfaces that's not covered by cartilage. It does help to produce the synovial fluid, but it also helps to contain the synovial fluid. Our second characteristic or feature is the articular cartilage. Now again, we did say articular cartilage is a remnant of the hyaline cartilage that we find on the bone surfaces at that particular joint. The functions include reducing friction during movement, so we want to have nice smooth movement. It does help to act as a cushion as it starts to absorb joint compression. And that helps to prevent damage to the articulating ends of the bones. So it's also a protective mechanism so that we're not getting specific bone-to-bone contact, and we also get, again, nice smooth movement. It does lack a perichondrium, and articular cartilage is avascular, meaning we do not have a direct blood supply to it. The third feature is a joint cavity. Now the joint cavity is that kind of space that we find between the articulating surfaces of each individual bone in the joint. It's going to be lined by the synovial membrane that secretes the synovial fluid. Now this synovial fluid is kind of a viscous or a thicker, oily type substance. And what the synovial fluid does is it lubricates and nourishes that articular cartilage that we find on those bone surfaces. Again, we did say down here it does nourish the tissue, but it also helps to remove the waste from the articular cartilage's chondrocytes. And again, just as some of the other features did, it also helps to act as a shock absorber. Again, fluid in there, it helps to increase a little bit of the pressure. And so as you have movement of it, it does act or disperses some of the pressure and some of the shock that occurs at those particular joints. Our fourth feature are ligaments. And so when we look at ligaments, ligaments really are going to help connect bone to bone. They are going to be a dense, regular connective tissue or made up of this type of tissue. And it helps to stabilize, strengthen, and then also helps to reinforce those particular synovial joints. We have extrinsic ligaments and intrinsic ligaments. Extrinsic ligaments are physically separate from the joint capsule, whereas intrinsic ligaments basically are the thickening of the articular capsule itself. And these intrinsic ligaments can include ligaments outside as well as within the joint capsule. Our fifth distinguishing feature is going to be the synovial fluid. Now, the synovial fluid is kind of this viscous or a little bit thicker, slippery filtrate that's really made of plasma and hyaluronic acid. And it is there to help lubricate and nourish the articular cartilage. Our sixth feature, specifically talking about the joint itself, is going to lead to a rich nerve and blood supply. We're going to see numerous vessels within the synovial joints, but we're also going to see significant nerve endings. Now, the purpose of the nerve endings and the nerve receptors are, one, going to help detect painful stimuli. So we're going to have what we call nociceptors. They also help to report on movement and stretch movements. Okay. Now, we have a specific name for the sensation that we're detecting at the joints. And that's going to be called proprioception. Okay? So proprioception is the body's ability to send signals that report on movement and stretch. So it basically, to put it more simply, it's a way for our joints to tell your brain where you are in space. It tells us how much bend or how much flexion or extension or what types of movements are at a particular joint. And this allows the brain to process that, interpret that, and then also realize, okay, this is where each individual joint is in relationship to the space around your body. One of the other features that isn't necessarily a distinguishing feature, but it is kind of a characteristic, are going to be tendons. Now, tendons are going to be composed of a dense, regular connective tissue, but they're not part of the synovial joint directly. But what they do is they help to attach muscle to bone. They also help to stabilize the joint. Now, we know this based on research, but also when you think about when you injure particular joints. So, for example, think about when you injure a knee or a knee ligament or an ACL. One of the things that we go through after surgery is really physical therapy. And it's not necessarily to strengthen the ligament, because we don't really strengthen ligaments so much as what we're actually strengthening of the muscle and the tendons that basically go over or cross a particular joint. And by having more strength in the muscle and more strength in the tendons, that's actually what allows us to stabilize the joints both prior to and after different types of surgeries. Another characteristic is going to be bursa sacs. Now, bursa sacs are fibrous sac-like structures that contain synovial fluid. They're going to be lined internally by the synovial membrane. And what we find is that in synovial joints, these structures are going to be found where bones, ligaments, muscle, skin, or tendons rub together. And so the purpose is to really alleviate any type of friction of the movements of these particular structures here. Okay? Now, they can be connected to, or they can be separate from the joint cavity. So if we take a look at the knee joint, you'll notice that there are numerous structures around the knee, but also there's numerous bursa sacs around the knee. And again, when we think about where they're located, these are going to be located in areas where there's an increased amount of friction. So down at the bottom here, you'll see that we have the infrapatellar bursa sacs, one on top, one below that patellar tendon. We have the prepatellar bursa, which basically is right on the surface of the kneecap. You'll see a couple others, the suprapatellar bursa, and then we see some in the back. But again, these are all going to be located in areas where there's some sort of friction, whether it's a tendon, a ligament, a bone, but that's what the purpose of a bursa sacs are for. A few other accessory structures. Tendon sheaths are basically elongated bursa sacs that wrap around the tendons. And this is where friction is excessive. We often see these in the ankle and the wrist, again, because we have excess movement in those regions. We also have different types of fat pads at different locations, and they're going to do very similar type things as far as protective. They act as a protective packing material in the joint periphery, and can also fill spaces when joint shape changes. Here we take a look at some of the tendon sheaths of the wrist and the hand. Again, you get a chance to see it basically surrounds the tendons in this case as these tendons roll into the fingers in the hand and part of the wrist. And so again, we just have these basically these elongated bursa sacs that are kind of going out and surrounding the tendon sheaths. Again, protecting these, around the tendons, basically protecting the tendons from friction in and around these areas. So when we look at synovial joints, we have, again, different classifications. And these are going to be classified by the movements allowed, but also by the shapes of the joint surfaces. We're going to talk about the classes of movement first. When we look at the movement of synovial joints, we have three different movement classifications. We have a uniaxial joint, a biaxial joint, and a multiaxial joint. Uniaxial joints really have movement in just one singular plane or axis. That's where we get the uni from. Biaxial, as you can guess based on the prefix, is going to be movement of that particular joint in two planes or axes. And then a multiaxial joint is movement in multiple planes or axes. When we look at the classifications then by joint surfaces, we kind of have a list here based on their classification from least movable to most movable. So we have plane joints, hinge joints, pivot joints, condylar joints, saddle joints, and ball and socket joints, and we'll cover all of those. So let's look at a plane joint first. So a plane joint has the articular surfaces really are a flat type of surface. This is the simplest type of synovial joint, and it has the least mobile synovial articulation. It basically gives us uniaxial movement, which basically means essentially one plane, and so it's really limited to side-to-side gliding movements in that particular plane. The example of a plane joint that we're going to talk about, or that we're going to use, is going to be the intercarpal joints of the wrist, okay? And so again, the intercarpal joints of the wrist between each individual carpal bones. A hinge joint is our second type of synovial joint. It's where we have a convex surface within a concave depression. It is also a uniaxial joint, and so we're going to see this almost like the hinge of a door. The example that we're going to use for a hinge joint is the elbow, where basically we're having kind of that flexion extension movements, and that's the only type of movement that we have. And so we have that movement within one particular plane. Our third type of synovial joint is a pivot joint. And the movement that we're going to see at a pivot joint really is exactly what it sounds like. So in this case, we're going to have a bone with a rounded surface that actually fits into a kind of a depression, and it's surrounded by a ligamentous ring. This is uniaxial movement, and so essentially we have rotational movement along a particular longitudinal axis. Now, we touched on this particular joint to a very small degree so far. This is going to be the proximal radial ulnar joint. Now, this is going to be found at the elbow complex, but it's what we see on the very outside or the lateral aspect of the elbow. And so what it does is it's the joint that allows pronation and supination of your radius and ulna over top of each other. So again, if we talk about proximal, we're talking about closest to the point of origin, and we're talking about the radial ulnar joint. So proximal radial ulnar joint. A condylar joint is our fourth synovial joint. This is where we have an oval convex surface articulating with a concave surface. Condylar joints are biaxial. And so when we look at condylar joints, these are going to be the joints that we find at the metacarpal phalangeal region. So where the metacarpals meet the phalanges that we find at digits 2 to 5 of the hand. Our fifth type is a saddle joint. Now, a saddle joint is an interesting joint. It's biaxial, and in this case, we have a concave and a convex surface, and essentially it resembles a saddle shape. And so we basically are getting movement in two particular planes. And the example that we have is going to be the carpal metacarpal joint of the thumb. And what this allows is it allows opposition of your thumb to actually touch the fingertips of all four of your other digits. Our last type of synovial joint is going to be a ball and socket. And this is the synovial joint that I'm sure everybody really knows of. It's the most easily identifiable. It's where we basically have a ball that kind of fits into a socket type structure. So we have a spherical head of one bone fits into a cup-like socket of another. These are multi-axial joints, and they permit movement in three particular planes. The most freely type of joint that we have in the synovial category is the ball and socket joint. So this is where we have the most movement. And the example is going to be the shoulder and the hip. So if we take a look at a graphic, I don't believe this is in your notes, but this is in your book. So you can go ahead and reference this there. But if we take a look at these, you'll notice that we have a chance to really take a look at all of these different types of joints. So if we look at the plane joint first, this is where we have the flat surfaces. These are going to be the intercarpal joints. Again, these joints just kind of slide over the top of each other. Our next one was a hinge joint. This is actually going to be what we call the elbow joint. We have the humerus here and the ulna here, and this allows for that flexion and extension type of movement. Over here we have our saddle joint. This is kind of that biaxial joint. We'll notice that's going to be here at the trapezium and the base of the first metacarpal bone. Again, this allows for opposition of that particular joint. So this is going to be the carpal metacarpal joint of the thumb. Here we have our condylar joints, and we see them kind of pull out the window here as we look at joints 2 to 5. So we see those. That's going to be the metacarpal phalangeal joint of the hand. Okay, so between the metacarpals and between the phalanx of each individual joint. We also have the pivot joint. Now there's two different examples that we talk about. We talked about the proximal radial ulnar joint, and that's going to be here. So just outside this window, you'll have the radius and the ulna. Now we're going to have what we call an annular ligament that basically wraps around the head of the radius here. And so the radius actually pivots or rotates within that ligament. And that's how we end up getting that supination and pronation of the wrist. The other location that we see is between the atlas and the axis, particularly between the dens of the axis and then the annular ligament here of the atlas. And you'll notice that that ligament basically holds the dens into place, and that then allows for pivoting movements or rotation of the atlas at the head location. So these are the top two vertebrae of your neck, and this allows for roughly 70 to 80% of the rotation of your cervical spine. And then you'll see here our ball and socket joint, which is essentially the head of the humerus, the head of the femur in one location as it fits into the socket, or we also have the location up in the shoulder with the head of the humerus into that scapula bone. So now we get into some of these particular type of movements. We kind of touched on what movements are at the locations of these joints, but now let's look at what these particular movements are. Most of this will be pretty straightforward and pretty self-explanatory. The first movement is going to be gliding. So gliding is essentially where we have two opposing surfaces that really just slide or glide back and forth or side to side over top of each other. There's really only limited movement possible in any direction, and it typically occurs along our plane joints, which we said really involve the carpals or our intercarpal joints, but we also have that in our tarsals in the ankle and our intertarsal joints. We also have angular movements or angular motion. Now, angular motion really is where we have an increase or a decrease in the angle between two particular bones. So here are a few types of these specific movements. We can have flexion extension. We can have hyperextension. We can have lateral flexion. We can have abduction and adduction, which you may actually hear me talk about abduction or adduction, just to clarify the pronunciation. And then we have circumduction. Okay. And this will be a great term to use for our attendance quiz for today, or our attendance code word, and that's going to be circumduction. So circumduction is going to be the code word for attendance for this particular lecture. So let's look at flexion first. So flexion is where we have movement in an anterior to posterior plane. And what it does is it decreases the angle between the bones, or essentially it brings the bones closer together. If you think about bending your finger, if you bend it down towards your palm, that's flexion. If you extend it and straighten it, that's extension. Okay, and we'll talk about that. We also can have that same type of movement at your elbow. Think about bringing your hand up towards your shoulder. That's going to be the flexion component of your elbow. If we look at extension, it's also in the anterior posterior plane, but it's the opposite of flexion. And so what this does is it increases the angle between the articulating bones. So again, example would be straightening your fingers after you've made a fist. So making a fist is going to involve finger flexion. Straightening your fingers is going to involve finger extension. Hyperextension is where the joint actually gets extended more than 180 degrees. And so if you are looking straight forward and you glance up at the ceiling while standing, that's where we've actually had hyperextension of your cervical spine or of your neck, because we can also have flexion and extension at your cervical spine. Flexion is going to be looking down at the floor. Extension is going to be coming back to normal. And then hyperextension is going to be bending it back even farther. Another movement that involves angular movements is going to be lateral flexion. Now, this is where we take the trunk of the body that moves in a coronal plane laterally. So we can see this oftentimes with our vertebrae, particularly in the cervical and lumbar regions. Basically, if you think about the cervical region, it's basically taking your ear and trying to touch your shoulder, or taking your hand and sliding it down your leg in the lumbar spine. That's going to be lateral flexion or lateral bending. So here we have a few of those examples as far as movements. You can see here we have flexion and extension at the elbow. Here we have flexion of the neck or of the cervical spine. Extension is back to normal. Hyperextension takes us even farther backwards. We can see this at the wrist as well, with flexion, extension, and hyperextension. Same thing at the knee, flexion and extension. And then if we look at lateral flexion or lateral bending, we can do this in the lumbar spine through here, or we could actually just take her neck, in this particular case, and try and touch her shoulders with it. Some other angular movements are going to be abduction and adduction. Abduction is where we have lateral movement of the body part that moves away from the midline. So this is as if we were taking your arm or your thigh and actually moving it laterally away from the midline of the body. Adduction is going to be the opposite. We now take the body part and we're moving it toward the midline. And so this is where we take the arm or the thigh after going through abduction and now bringing it back towards its resting position. Take a look at abduction and adduction. Abduction is moving this arm away from your body. Adduction is moving it towards your body. Same thing here with the wrist. Abduction is moving it away from the body. Adduction is moving it toward the body. Same thing with the leg and the hip. And then you can also see here with the fingers. You basically start right here with the middle finger. Abduction, we actually are moving it away from the midline of the actual palm. Adduction is now moving them back together. Let's take a look at circumduction then. Circumduction is where we have the proximal end of the appendage relatively stationary, but the distal end of that particular appendage makes a circular motion. And so essentially it's like making a cone in space. And so thinking of drawing a circle on the blackboard or just taking your shoulder and basically making a circle with it. That's going to be circumduction here. This is going to be circumduction here with your hip. We also have a few rotational movements. So with rotation, we have a situation where the bone pivots on its own longitudinal axis. If we look at lateral rotation, we're taking the anterior surface of a bone laterally. If we take medial rotation, this is the turning of the anterior surface of a bone medially or back towards the middle. Pronation, if we look at pronation when we look at the hand or the forearm, this is where we have the forearm so that the palm of the hand is towards the posterior or facing backwards. Supination is lateral rotation of the forearm so that the palm of the hand is facing the anterior. One way that we typically, or that I have typically learned to do this, is at least learning supination. And the way I remember supination is I basically try to hold a cup of soup in my hand. And if I do that, I have my hand and my forearm in a position of supination. And that way the opposite then is going to be pronation. So let's look at a couple of these examples here. Obviously we have rotation, we have right and left rotation. This is simple rotation. But if we look at the shoulder, we also have lateral rotation where we're moving that particular bone laterally, particularly when we look at the shoulder. Medial rotation, we're rotating it back inward. Lateral rotation of the hip, we're pulling the toe pointing outward. Medial rotation, we're actually pulling the toe so that we point the toes inward. And then we look at pronation and supination. Again, pronation, the palm of the hand is facing to the posterior. Supination, the palm of the hand is facing the anterior. And then we have a few special movements that really don't fit into any of these other categories. So when we look at depression as a first movement, this is where we have inferior movement of a body part. And so we're basically taking the movement of the mandible, and this is opening of the mouth. So we have the mandible basically dropping or depressing itself. Elevation, we also look at the mandible, and this is where we have superior movement of a particular body part. So this is taking the mandible and actually bringing it upwards, and this is closing the mouth. We can also look at depression and elevation from a shoulder perspective. You can see depression is where the shoulders basically drop straight down. You can also look at elevation where the shoulders actually are elevated or brought to the surface or brought more superiorly. We also have a couple examples of movements that occur at the ankle. And this is going to be dorsiflexion and plantar flexion. Dorsiflexion is going to be really limited to the ankle, as is plantar flexion. And this is where we have the talocrural joint, or the ankle joint, is bent so that the dorsum of the foot moves towards the leg. So the dorsum is going to be the superior surface. So it's the top of the foot. In this case, we're actually pulling up. Okay? And so basically you're trying to dig your heels into the ground. Plantar flexion is the opposite. This is where we take the talocrural joint and is bent so that the dorsum is actually pointed more, is more pointed inferiorly. So this is basically trying to walk on your tiptoes. This is full plantar flexion. We also have inversion and eversion. These also are occurring at the ankle and at the intertarsal joints of the foot. This is where the sole turns laterally. So this would be what we call an eversion sprain of the ankle, and this is the worst of the two. An inversion sprain or an inversion movement occurs at the intertarsal joints of the foot, and this is where the sole turns medially. So if you were to injure your ankle in an inversion sprain is the common type, and this is where, again, the sole is actually turned medially. And then we also have protraction and retraction. Protraction and retraction really take place at the jaw, or the TMJ, the temporomandibular joint. And with protraction, we have anterior movement from an anatomic position. So protraction is essentially jutting your jaw anteriorly. Retraction is the opposite. This is where we have posterior movement from an anatomic position. So essentially we are taking the jaw and really pulling it backwards, okay? So pulling the jaw in a posterior fashion at the TMJ. And then lastly, we have opposition and reposition. Opposition, we've talked about, occurs really with the thumb. And this is where we have the movement of the thumb towards the tips of the fingers at the carpal metacarpal joint. And again, this is the opposition movement. It enables your thumb to touch the tips of your fingers, and that allows us to grasp things. Reposition then is basically the opposite movement. It's really just moving back to our original position. This will be the end of today's lecture, and then we will pick up with levers in our next lecture.